Good afternoon, everyone, and welcome to the Baldrige Foundation's quarterly webinar. As a reminder, due to the high number of participants, everyone will be kept on mute during the presentations. If you have questions, please submit them to the moderator in the questions box located on your control screen. Presenters will answer questions during our panel discussion. Here's today's agenda and featured guests. Our four presenters today are stellar, well-known national and international experts in the field of healthcare. First, Chuck Stokes, founding partner at Relia Healthcare Advisors. Roland Stacy, Director, Graduate Programs in Healthcare, University of Colorado, and partner, Guidehouse. Benjamin Anderson, Vice President, Rural Health and Hospitals, Colorado Hospital Association. And Jane Pope, CEO, Hill Country Memorial. Their presentations will be followed by questions from the audience, and then brief updates from Bob Fagmeyer, Director of the Baldrige Program, Brian Lassiter, Chair of the Alliance for Performance Excellence, with a few closing remarks. And now, it is a privilege to turn the presentation over to our first guest, my good friend, Chuck Stokes.
Thanks, Al, and good afternoon, everyone. I'm going to start my remarks here about understanding and prioritizing the community healthcare needs assessment from a post-COVID framework. And we know that in rural healthcare, there's always going to be more needs than you have resources to fund. And so one of the things that I think most healthcare organizations do is they fund, every year they look at their community needs assessment. Some people do that annually, some people do it every other year. But I think the community needs assessment really informs the organization, really how it needs to look at what its priorities are. How do you identify the deficits from that community needs assessment, and how technology can help meet some of those needs. And then there always comes the time where you have to reprioritize your capital needs because resources are limited. And so when you're looking at the needs assessment, how do you go about prioritizing what the community needs assessment informs you to do? Well, I think it's a great opportunity for a lot of communities to really embrace the concept of diversity and inclusion and really get the community's feedback about what they feel is a good priority. And you can certainly do that by reaching out to like the Chamber of Commerce, Better Business Bureau, the religious community, public health within your community. And in some cases, I think that, in today's world, I think you can look to like the police department, because the police deal with a lot of social disparities that end up in our healthcare organizations. But my point is that it's a good opportunity to be inclusive within the community's business community to help set some of these priorities. And then when you're looking at technology needs, what are the technologies that your community is willing to embrace? Telemedicine, virtual care. I think most of us healthcare professionals feel that horse has left the barn in a post-COVID world, because it's going to help us recover faster from a financial standpoint, but it's also a strategy to become more consumer-centric in your healthcare delivery within your community. I think things like looking at technology that manages chronic disease, such as congestive heart failure or COPD or diabetes. There's all kind of technology today that's not very expensive that can help keep these patients out of your hospital, out of your emergency room, and to a great extent, really out of the primary care physician's office. And then technology that helps teach patients about actually when they need to seek care. And so I think there's a lot of technological tools that are in the marketplace today. It's just taking a look at your community's assessment and say, what is the technology that will help work best for my community? And then reprioritizing the capital needs. As we know, resources are limited, but hopefully your community needs assessment serves as a data-driven format for you to decide on where to invest your scarce resources. And I think that spending on technology and programs that promote health are good investments for the future, because we have to figure out ways to keep chronic disease patients more well in their home environment than in the most expensive aspects of the delivery system. And then looking at partners, which I'll talk about in a little later on, is partnering with providers and others to take a look at technology and programs that address those issues. And as we think about rethinking our partnerships, what kind of partners do we need? And again, I go back to looking at community needs assessment should play a big role in helping us identify what partners. And I think that do you need a joint venture? Do you need a joint operating agreement? Do you need a merger? Or I call it OWAs, or other weird arrangements. What type of partnership do we need to sustain our organization? And then how does the new partnership help better serve the community? Because I think that when you look at these different type of partnerships, you always go back to your organization's mission, vision, and values and say, and again, question, do I need a joint venture? Is that going to be, am I going to be better off with a joint venture? Or do I need a merger? Do I need something to be part of a bigger organization for scope and scale? Should we have another pandemic or some other horrific event that happens? And then when I look at the concept of better serving the community, do I need a technology partner? So that, again, we talked about telemedicine and virtual care, and it seems like people are embracing that. There's a learning curve with that, as we all know, but again, I think that is just a way of life for the future. And then, do I need another hospital partner? And another hospital partner could be another rural hospital that's 25, 30 miles down the road from you. And are there ways for you to work collaboratively together? Can you form a joint operating agreement for certain services or certain technology to partner? Or you might need a tertiary partner and for specialty care in your community. And I've used this example many times, is your community might not can afford to go recruit a neurologist that might cost the healthcare system $300,000 to see 8 patients a day. But you could partner with a academic medical center or a tertiary provider, maybe 90 miles away, and they could put a stroke robot in your emergency room, or have a world-class neurologist available for virtual care visits or telemedicine visits to serve that population within your community, and do that in a high reliability format. And then, or do you need a merger for long-term sustainability? And of course, if you think that that's the right thing to do, how do you go about the due diligence in choosing the right partner? And again, I think that's really ties back to mission, vision, and values. And then which partner can really help you most in dealing with aging population and chronic disease process? Because all of us, we know we have an aging population in the country, and we're getting ready to really consume more healthcare resources than we've ever consumed in the history of our country over the next 20, 25 years. And then finally, reimagining your workforce. And this is one we could talk the whole time about, but certainly recruitment and retention it was an issue with us in healthcare and for rural healthcare prior to the pandemic. And I think that one of the things that you're going to see in the pandemic is that you're going to see baby boomers retiring at the end of this, and you're going to see some caregivers just saying, I emotionally have to take a break, or I'm leaving the field of nursing or pharmacy or what, and I'm going to go to work for a different type of organization. I'm going to go to work for a technology company, an informatics company, because the trauma of COVID and the stress and the burnout that's prevalent with physicians and allied healthcare professionals is really daunting. And so it is a great time to recruit people into healthcare, because the public's view of physicians and allied health professionals has never been higher. It's in the 90 percentile today. And so I think it's good to have community recruitment initiatives that you can recruit these individuals to your organization. I think that you're going to see, again, cross-training of professionals. We know that nurses, we can train nurse techs to do a lot of things that nurses do. And I know that there's nurse practice acts within states and things that by law and licensure only nurses can do. But we have to step up our training in technical jobs for nurses, pharmacists, physical therapists, respiratory therapists, et cetera, and train them to do things that would take task off of our licensed professional caregivers. And that's a whole nother topic within itself, but I think we're going to see that that's going to be necessary. And I think that there's an opportunity to do some cross-training between public health workers and home health workers, or home health workers and hospital workers. The emergence or convergence really of home health, public health, and hospital work is really, COVID has really shined a light on these disciplines, and there's probably really buku opportunities for people to work together. And I think that physicians, the same thing with cross-training with physicians. We see a lot of opportunities for like emergency department physicians and hospitalists, so that they don't get burnt out, and there's some variety in different, and they can see patients of a different kind on a day in, day out basis, and not just get burnt out from working in the emergency room. And then certainly advanced nurse practitioners, we're going to see expanded roles in those for the future. But I do think that job sharing between public health and hospitals and social workers and behavioral health professionals, there's a lot of opportunities. And a lot of these jobs actually could be shared between your community and your neighboring community. And if you're having a hard time, you got more nurses in one community, let them come over and help in times of surge of business in the other rural community would be very helpful. And then finally, what are the new roles that may be envisioned in a post-COVID-19? I think there's a ton of new jobs that we have not really foreseen, but we anticipate. And when you look at telemedicine and telehealth and virtual care, there's some technical type person or level of skill set that's going to be required to help nurses and medical assistants in the private setting be able to provide virtual care and telemedicine in a safe, high quality, high reliability way. And I also think that there are new roles between public health and possibly between policing. As we look at social unrest, police see a lot of the social disparities in the community. And there may be new partnerships and new roles between healthcare organization and policing and public health that emerge for the future. And I'm not going to be surprised if we don't see that happen. And everybody knows that tracker and tracers now throughout the country, because of COVID, has kind of emerged as a really big skill set. Even though that discipline has been around for a time, it seems like it has expanded. But I do think that there's ample opportunity for cross-training, recruiting new professionals into the industry, and job sharing between public health, hospitals, and home health, and other community agencies. So I'll turn that back over to you, Al.
Thank you, Chuck. Extremely interesting. Our next guest is Dr. Roland Stacy from the University of Colorado. Roland?
Thanks, Al. I appreciate the chance to be here. My first love in healthcare is rural medicine. So I was the CEO of a small hospital in Leadville, Colorado, and I've always stayed mindful of the unique issues. And I think we've got a panel here that can really help as we try and address some of those things. The first thing is that whatever we do, we've got to make sure that we maximize revenue. The revenue lost to the entire industry in the past 90 days has been significant. And if you're not too late, I would do everything you could to make sure that you understand and avail yourself of all of the opportunities through FEMA and the CARES Act and other opportunities to shore that up, because it's such a burden to rural organizations, I think, disproportionately. Then we have to start to explore other alternative revenue models. Chuck talked a little bit about telemedicine. It is so interesting to me that for my whole career, literally 2 decades, we've been working to get telemedicine and digital strategies accepted in the industry. And for 20 years, it's been unsuccessful. And then in 2 months, it's now the norm. And if you're not there, I would suggest that you get there fast, because in rural environments, telemedicine is going to become increasingly important. Connection with referral centers will be important, and it will be mandated as you try and find ways to reduce your operating costs. I don't know about the future of cost-based reimbursement in rural organizations. I can't imagine that it's going to be here forever. I've said that for my whole career, and it's been here forever. So, but it really does feel like eventually cost-based reimbursement is going to be a thing of the past. I believe Chuck talked a little bit about the Nurse Practice Act. I'm also going to talk about the Medical Practice Act in your state, because the Medical Practice Act also governs how you use nurse practitioners and physician's assistants. And I believe that in the future, for rural organizations of any flavor to be successful, we're going to have to find out how to better utilize nurse practitioners and physician's assistants, and it is going to be tied to our ability to give them more autonomy, not less. And that's a Medical Practice Act issue that we're going to have to work with. So I would work with your state hospital associations. I would work with the American Hospital Association, do whatever we have to do to find ways to increase that for rural healthcare. The American Medical Association will fight this every step of the way. And so we just have to be aware of that, and understandably, I mean, I understand what their theory is, but for rural medicine to be successful, I think that that's what we're going to have to do. Not all rural environments or organizations have the blessing of cash on hand to create a non-operating income, but now nobody does. After the change in the market, I think we can all predict that our future is going to be governed by our discipline, not by our non-operating investment income. And I don't know that we'll be successful without finding ways to be disciplined. The opportunity to work together in M&A is now the time, perhaps, but only if it brings us more discipline, not less discipline. I'm working with several organizations now who are finding that the productivity in their organization is under more scrutiny than ever, and they're finding ways that they have to mandate that the productivity is increased in the future because of the scare of the last 90 days. We have no more time for latitude, and now is the time, I think, to really just have a discussion. When you shut down a portion of your work, most notably the outpatient delivery system, as many have had to do, this is the time to evaluate what do we want to bring back, what is needed to what would a highly disciplined organization do as we bring back, who would we bring back, and how do we monitor the services that we provide? Now, I will tell you, I'm a Baldrige process guy. I continue to believe and would debate anybody on earth that the Baldrige process is the best performance process on earth. And I think that organizations that become disciplined in the process are better able to take care of their current environment than others, because the process forces you to plan for times just like this. You have to be ready. You have to go through this process every year and be ready. And I would encourage you, if you're not, to get more engaged in this as we go forward. So, Al, that's my story, and I'm sticking to it.
Thank you, Roland. Very insightful. Next, we're going to have my good friend Benjamin Anderson from the Rural Health and Hospital Association, Colorado Hospital Association. Benjamin?
Thank you very much, Al. I'll jump right in. I joined the Colorado Hospital Association back in November after 10 years as a rural hospital CEO on the Kansas-Colorado border on the Kansas side, and what the Washington Post deemed the 10th most remote town in the United States. It wasn't a contest we were trying to win, and we didn't even know we were in it, but it ended up being helpful for some grant money. Anyway, I spent a while there leading healthcare delivery systems that served about 20 counties in Southwest Kansas, and then was recruited to CHA to develop a statewide strategy for rural health. And I just didn't know it was going to be like this. So we had just finished, after 3 or 4 intensive months of listening and being on the road and learning from rural hospitals in Colorado, just finished and presented a strategy on the 5th of March. And on the 6th of March, COVID was declared a statewide emergency in Colorado. So that, of course, changed the course of where we were going. But what we found as we developed this vision around value-driven systems and increasing capacity and innovative payment structures that optimize health and strengthen rural communities is that this strategy, with these 4 focus areas of leveraging data, increasing workforce and leadership capacity, improving access to care, and strengthening collaborations, those are still relevant and even more relevant now. And so now what we know is we have a strategy that is battle tested, because what's happened is we've actually been able to accelerate the impact that's happening here. And so one of the things that we found that was helpful, and perhaps you all would be receiving this the same way or thinking this, is that folks are looking for a playbook in a post-COVID world, specifically to rural. So what does it look like for these priorities? And I'll get into what we're doing to address that, but Al, if you'd advance the slide. Colorado, COVID hit Colorado like a brick. It happened very, very quickly, and it was very shortly after that rural conference in March that we saw numbers just skyrocket in Colorado, and we saw it happen really in a period of 1 week. And we saw diagnoses climb. We saw hospitals the confirmations for COVID climb, and we also saw the ICU patients, the number of people admitted into inpatient beds with COVID skyrocket, really to even surpass 600. And we only really had 1,100 ICU beds in the state. And so we saw that if that trend continued, and we were about a week behind New York, if that trend continued, we were going to utilize every ICU bed and have to go into crisis standards of care, determining who got oxygen and who didn't. And so I remember at this moment, a conversation we had with our Vice President of Clinical Affairs, Dr. Darlene Taddy. We were on a virtual call at that time because we'd already begun to work remotely, and she said, if we don't end up seeing people die due to lack of access to oxygen or ICU beds, or our hospitals being overrun, if that doesn't happen, it will be because behind the scenes there were people that were fighting like heck to make sure that didn't happen and had to make very difficult decisions. And that includes at the governor's office and in the public health departments, and also within the healthcare delivery systems, that we had a lot of really courageous people in Colorado and across the country that were preventing that from happening. And so we we saw somewhere around the last several days of March some significant social distancing measures put in place by the governor, supported by the hospitals, really in a collaborative way. And I think it's worth noting, and many of you have probably read in the news, that going into this COVID deal, like really on the 4th of March, the Hospital Association and the governor's office were having a very different discussion that was not about COVID, but it was around public option. And these two entities had every reason not to collaborate. They were in a dead heat on a very controversial issue that had gotten national attention. So that was March 4th. And by March 6th, they said, we have to put that aside for now and make sure that people don't die and make sure that we optimize the care folks. So I think highlighting that collaboration is essential, also that it's possible. Because if the governor's office in Colorado during the legislative session in such a heated conversation around that, and the hospital association could partner the way it has, really collaboration is possible and it can save lives. So I've communicated the extent or the way Colorado was hit by COVID. If you'd advance, Al. These were the 4 areas that we found were most relevant or the most common challenges for our rural hospitals across the state. And we would categorize them as the 4 S's: staff, supplies, space, and spending. And I won't go through each subcategory, but really we put them in 4 buckets, these 4 buckets. And we knew that we were going to need to solve problems. We were going to need to solve them in 4 buckets. And so what we've done that we hope is relevant, not just in Colorado, but elsewhere, is we've secured a grant from the Zoma Foundation here in Colorado to produce a post-COVID best practice rural healthcare delivery system toolkit and playbook that will be done by August 30, really in preparation for new surges. So we needed it to be done quickly, and we also needed it to be done well. So just yesterday, we solidified it, the list of the key informants. We'll be interviewing Angel Flight West and the Colorado Civil Air Patrol will be flying our researchers with the Farley Health Policy Center and CHA and the medical school around to these interviews, and which will be a combination of hospital CEOs and other administrators, frontline workers, clinicians, public health experts, governance people, really putting them interviewing those folks and also looking over all the community health needs assessments in our state and synthesizing those and really developing out a best practice playbook that will include how do we utilize PPE, as Rulin mentioned earlier, how do we maximize cash or maintain the cash status that we have right now? How do we manage staffing, as Chuck was talking about earlier? What are the efficient ways to do that? Really putting all of that in a playbook for folks and then releasing that. And then phase 2, which we're still seeking funding for, is a white paper that will produce policy recommendations that can back up that playbook. A lot of what's in the playbook really it doesn't require policy changes. It's just good quality, really Baldrige consistent, good quality best practices that in bite-sized ways that rural hospitals can take on. So I'm excited to release that. If you go ahead and move forward. One of the things I'll just touch on briefly is a program or project we put together called Heart for Heroes, and you can find hashtag Heart for Heroes on YouTube or heartforheroes.org on the internet, and it can explain more about this. But essentially, we went through a non-governmental approach or developed one, a private foundation or philanthropic approach to solving the PPE problem for rural Colorado. So what we did was we engaged Angel Flight West and Angel Flight Central, 2 networks of thousands of volunteer pilots that donate their plane, their gas, and their time, who weren't flying people at the time to appointments. Typically, they fly people to specialty appointments, but that was shut down because of COVID. So they volunteered their planes, their gas, and their time to deliver PPE around the state. And so what we did was we partnered with the governor's PPE task force. We partnered with Project Cure, with an organization called Make for COVID. These are organizations that are making or procuring large amounts of PPE, and they had committed to send it out to the end of the supply line. So essentially, what Heart for Heroes has done with Energize Colorado, which is more from the governor's PPE task force, is take those resources and hack the supply chain, send the PPE out to the end of the supply line where it would be least likely to land. And so we've to date delivered about a quarter million pieces of PPE out to rural Colorado, and these planes show up in the nearest landing strip to these rural hospitals. And this has been, I bring it up on this call because it is scalable nationally, and perhaps we can talk about this after the presentations, but that can absolutely happen. And so we have our nurses that are posting the fact that they've received this PPE on their social media sites, sending people back to the video, sending people back to the website, so local folks can contribute, put more fuel in the tank so that more PPE can be purchased and sent out to rural Colorado and the other safety net providers. So Al, if you'd continue to advance. The lessons we've learned from this in conclusion: how do we align priorities was a question that we began asking, especially going in the legislative session going into this COVID situation. Lesson we learned: we must serve as leaders as a steady guiding North Star, always pointing back to and intuitively, what is the right thing to do here? What is the thing to do that will communicate the value of human life and dignity? What is the thing to do that is sustainable? What is the thing to do that will protect our communities? And that's a complex question to answer, but as leaders, we've got to be synthesizing that and asking those questions in a collaborative way that brings other people into that discussion. Secondly, why did it take the crisis to get here? We believe that COVID-19 highlighted and exploited the hairline fractures in our system. There are inequities. Anybody that's in healthcare really can acknowledge the differences, the disparities between race, between gender, between insurance status or zip code, especially rural to urban. Some of the deepest disparities in our country are between rural and urban. And what COVID did was highlight those and make them impossible to ignore anymore. And because we know about them, we must do something. Sister Mary Jean Ryan, who is the CEO of the first Baldrige award-winning hospital, SSM, has taught me over the last 10 years that any harm that is avoidable is morally unacceptable. And once we know about it, we must act, we must address it, we must develop systems to solve it. Third question is, where are the solutions? As leaders, we must listen to the people most affected. We must get to the front line. That's part of what that playbook is about, is getting to people that are touching patients in a rural setting for COVID and asking them, what is it like being adjacent to a beef packing plant with a bunch of people who can't socially isolate? How do we help you? So how do we develop systems that support you? And then fourth is the collaboration. Is it required or is it best practice? And I think, put simply, people die if we don't. They die if we don't. And so the governor's office and the Colorado Hospital Association can work together in the middle of a legislative session. We can do that, and we must, because people's lives are at stake. So that really summarizes my presentation. Al, I'll turn it back over to you.
Thank you so much, Benjamin. And now it is a privilege and an honor to introduce one of the most famous people in rural healthcare, especially within the Baldrige community, Jane Pope, the CEO of Hill Country Memorial. Jane?
Thank you, Al. Really, it's an honor to speak with the other speakers today, and I'm hoping to build off of what they've said. What we really focused on was, what did the Baldrige framework teach us, and how could we utilize that through this process, through this crisis, and not forego our strategy or our core competencies, and yet not have rigidity. And so our three core competencies are excellence-driven, visionary, and relationship-driven culture. And I want to talk about what examples are that we used in each of those core competencies. So the first one, if you'll go to the next slide, Al, is excellence-driven. And we put in place, thanks to the coaching of our Baldrige coaches, and I'll just do a shout out to Jordan Johnson, who challenged us earlier this year to re-examine our organizational rhythm. And we put this racetrack in place for the beginning of this year. And strategic breakthrough initiatives are 90-day working plans. And I'd like to say we had some forethought, that we put cross-training in place for the second quarter. Really, COVID really amped up all of that cross-training. And so all of those strategic breakthrough initiatives and having our rhythm was critical for us, because what I've shared with our team is We're going to get through COVID. I'll tell you right now, it doesn't feel like we are, but we're going to get through COVID. And we had this very important strategy that we got inputs from our community, we got inputs from our team on, and we need to execute on that. We don't want to be rigid in it. At the same time, we need to execute for the good of the people that we serve. And so this racetrack really helped us stay on focus and ensure that we were meeting the needs of our communities. And so the next slide is around our technological infrastructure. You heard Rulon say about challenging us to look at the Baldrige framework. It's part of what we do every day. You heard information about cash flow. I needed to look at, wow, we just took a huge hit with not being able to provide as many elective procedures. And yet I knew there was technological needs that we had. And so we took some intelligent risks. And certainly televisits, as Chuck said, it's out of the barn. And we knew that one of the needs of our customers was access. And we quickly got those televisits in place. In addition, we had already had a tele-ICU initiative and reached out to them to say, could you be our COVID leads through televisits? And they agreed to do that. And so we had that in place. We were fortunate enough through Texas Hospital Association to be chosen as a beta site for Care AI, so an artificial intelligence thermal scanner for temperature reading. And I would highly recommend this product to anyone, and I'm not selling it, but we are able to have our team members have their temperature taken at each of the doors through this thermal scanning without having to have a staff member there doing that screening and collating it. It's all done through that Care AI. So taking that intelligent risk was critical for us. And then with our coaches, we said, gee, we're not sure that we're going to be able to execute on all of the strategies, the performance improvement initiatives that we had in place. In fact, we talked to each other and said, I think it's going to be impossible to do a virtual Kaizen event. And what we learned was we learned how to do virtual Kaizen events. And so we've done digital education offerings for those we serve. We've done digital education offerings for our team because we wanted to invest in the team and in the community for the future. So the next slide is about that visionary. And so you can see our strategy map there where, as I said, we've executed on performance improvement, performance excellence through virtual mediums. And we have many members of our team meeting weekly for our SBI report outs, a strategic breakthrough initiative report outs, where I'm able to see them on the screen. They're executing on this strategy map. And what we say every day is this strategy map is simple. The more complex it gets, the simpler it gets. We believe that's simple. And every team member executes on that. That isn't an executive team strategy map, that's our team. And we've been able to engage them through this virtual forum. And I will tell you, I believe we have advanced our strategy more through COVID than perhaps we would have without that push. And so lastly, the last slide I want to talk about is relationship-driven culture. That is one of our key core competencies, is that we build relationships. We put a community support hotline in place. One of the technological things that we found as well is that we could try a bot where people from the community could put their questions in using artificial intelligence. And that was really, really helpful for our communities because they didn't necessarily want to come to the hospital, but they wanted their questions in place, answered. We did drive-through testing. We were one of the first in our areas. We were the first in our area to do drive-through testing and ensuring that we were there for our community physicians so that they could get their patients tested. We did virtual stakeholder town halls over and over again, and we continue to do those. And I will tell you, I was one of the first people to say, I'm not sure I want to do that. Relationships are important for our team. And I think it's important we do it face to face. I learned a lot through this, and that there's a way to do that community support. And then we made a commitment to our team that we wouldn't furlough them. You will see that under the resilient workplaces. We went out to our community and asked for philanthropic support, and we made some decisions in order to ensure that, because our independence is critical for us, that we wanted to maintain that, and our community wants that. Mental health support. Chuck talked about community health needs assessment. In our community health needs assessment, we learned that mental health support, behavioral health support is critical. We put measures in place for our team and for our community. We have flexible work arrangements, and we ensure that there was daily communication with our team. So lots of communication to ensure that we had that resilient workplaces. And then lastly, that pictorial is our new strategy map, and it is a transfer of all of those words. That, again, the more complex it gets, the simpler we get. We really made this much simpler, so that road is our mission, the vision's at the end of the road, and all of our objectives are on the side, and all of our key foci. And so that has really resonated with our team. And we've had that opportunity to look at what is it that we do well and what could we improve through this process. So that concludes my talking points. Thanks, Al.
Thank you so much, Jane. And now we'll go to questions from the audience. And the first question goes to Roland Stacy. Roland, given all the changes of the last few months, do you think the delivery system in rural America will change in the future?
I do, Al. I think it has to. I think that it will be a component of increased independence for mid-level practitioners, which they hate being called that, nurse practitioners and physicians assistants. I think that it will be that, a combination of telemedicine and a combination of affiliations, mergers, and other relationships. But we can see it happening even now, that we're just not going to be able to continue in the way that we have been. And I think that those things will all add to the complexity going forward. So yeah, I appreciate that question.
Thank you, Roland. Our second question is for you, Jane. It is clear from your presentation that the Baldrige criteria is a cornerstone for how Hill Country Memorial operates. You laid out clearly how you and your team have used the criteria as a framework to navigate these past few months. Considering there would be a resurgence in the fall, how do you think the framework will help you navigate that potential change?
What I've decided in the state of Texas, that we're not going, the resurgence is now. And so as I look at the strategy map and I look at the framework, one, I'm really glad that we have that framework and that discipline. And even the slides that we submitted in that racetrack, the SBIs for the third quarter have changed based on the needs of the community. We have now a strategic breakthrough initiative plan for wellness. We have a new wellness center being built, and we said to ourselves, let's pause, let's go back to the framework, let's think about what the needs of our customers are, and have those changed post-COVID. Are people going to go back to gyms like they did? And let's look at our footprint and how we deliver to our team, how we deliver to our community, as well as experience. We added a patient experience SBI because it's different now. It's different with televisits, and we need to develop and hone some skills in that and still meet and exceed the needs of those that we serve. And so the framework really has helped us and will always help us. And those are a couple examples.
Thank you, Jane. Our third question goes to you, Benjamin. Describe how the PPE procurement and distribution model your team deployed in Colorado could be replicated in other states.
Yeah, thank you, Al. It's really very simple. It's already being replicated in other states. And so if you go to the heartforheroes.org website, you'll see sort of how it works. But essentially, requests are being made for PPE through Project Cure. Project Cure is not able to fill every request for PPE, but is able, I mean, they're sending out, I mean, at this point, well over 2 million pieces of PPE all over the country. And then those include N95 masks and booties and gowns and surgical masks and face shields. And I mean, they sent a ventilator to a rural community in Northwest Colorado on an airplane. They just put it on a small airplane, got it there. They had a biotech technician make sure that it was safe and operational and send it out. They're sending out equipment and supplies all over the country. And I think over a dozen states have received these shipments. There are no cost to any of the recipients, these hospitals that make these requests. Whatever comes to them, and it generally comes somewhat quickly, it comes at no cost, which includes transportation or the distribution of these products, but also the products themselves. So you can contact Project Cure through that. You can also email me, benjamin.anderson@cha.org. I'd be happy to forward any requests and get you connected to the right people. But the intent is that as healthcare workers are receiving these, they're posting pictures online wearing a piece of PPE saying "Heart for Heroes, Project Cure, thanks for the PPE." And right now, healthcare workers have a tremendous amount of influence in our country, and so we're just leveraging that on social media, and that will encourage social networks that really want to make a difference, support to make contributions through Heart for Heroes to Project Cure, which they use to purchase more PPE and then distribute it out to rural places. So if anyone has any questions about that, happy to connect you. I know they're leveraging the Angel Flight networks across the country. So it's not just on the West or in Colorado, but around. We've got distribution systems to get that done. And Project Cure is a national organization that has 7 warehouses across the country too. So it's not just based in Denver. So there's a real opportunity to meet some needs nationally. The National Rural Health Association, Brock Slabaugh, the executive vice president there, is also very involved in this and is aware of it. And so you could go through NRHA, through Brock, or email me, or contact Project Cure directly and say, how do we get this done? Most of their efforts remain domestic, even though they're traditionally an organization that focuses on international work. They're really working to take care of rural hospitals around the United States.
Thank you, Benjamin. We've got time for one more question for our panel, and this one goes to you, Chuck. You have discussed community needs assessment, understanding your customer, evaluating potential partnerships, and reimagining the workforce. These seem to be pretty intense initiatives for most rural hospitals. Do you think most rural hospitals have the bandwidth to juggle, multiply lofty initiatives like these?
Well, very good question. I think that hospitals across the nation, whether they're rural hospitals or community hospitals, have a difficult time juggling all the initiatives that they have to juggle today. I think in rural healthcare communities, I think it's more challenging because I was reading a Becker's report last week, and they said that over the last 10 years in the rural healthcare, we have lost 130 hospitals over the last 10 years, and 1 in 5 Americans live in rural parts of our country. And when you start thinking about it, and the ones that have really lost the most hospitals are in non-Medicaid expansion states. So Jane and I share the distinct pleasure of having the state that has lost the most rural hospitals, which is Texas. They've lost 21. I think Tennessee lost 13. Oklahoma was 8. Alabama 7, Missouri 7, North Carolina 7, and then it kind of goes on down. But those are substantial losses when you think about 1 in 5 people in our country living in a rural area. And Ben referred to this, and I think he was spot on in this in his comment about collaboration is going to be absolutely essential for rural hospitals in order for them to meet their community needs and be sustainable over the long run. You're going to have to collaborate. And so when I put out just some options there about partnerships, I do think that rural healthcare is going to have to look at the partnership between public health and their hospital, because again, COVID has pointed out things that we've actually known in the industry for 20 years about social disparities, because these individuals have ended up in our emergency rooms because of homelessness or food insecurity, and all no access to primary care, medicines, other services. And behavioral health is huge. Our emergency rooms in the communities are filled with a lot of behavioral health patients. They're not there for medical emergencies. They're there for behavioral health. So the relationship and collaboration between public health, rural hospitals, and referral centers, the tertiary referral center and academic medical centers, there's going to have to be some kind of redefined relationship of collaboration, because rural healthcare cannot be, again, all things to all people. The resources are not there, nor is it really plausible to think that you're going to have the bandwidth in some of these communities to execute on the strategies that you have to execute. So I think there are going to be all kind of new partnerships going forward and emerging as a result of it. I do think that all healthcare systems, whether you're rural healthcare or community healthcare, you need a solid operating model. And all of our panelists have referred to that. And Baldrige serves as that framework to put together an operating model that really informs you about your workforce, about your strategy, about your consumer, and how to tie all of that together to make you financially sustainable over time and to grow. And I've said this many, many times. It's like the kind of the Baldrige formula for success, but engage physicians and employees delivering exemplary quality and safe care and exceeding customer expectations. They don't have to worry about the financials. The financials will take care of themselves, and they'll have the resources to continue to grow. But you have to have that operating model in mind that really delivers that model. And I think that what you're going to see over the next probably year and a half is you're going to see organizations having to struggle with partnerships, employee engagement, redefining your workforce. It's huge. It's not going to go away, but it has to be done. And to Ruland's comment about having the agencies that license and certify these employees and the educational systems that train these employees, we're going to have to reimagine our workforce and reimagine new jobs that don't exist. Because my feeling has always been, even if the education system could turn out all the doctors and nurses and pharmacists that every healthcare organization needed across the country, for the future, you're not going to be able to afford them. And you're going to have to find some alternatives to getting that work done in a more efficient way.
Thank you, Chuck. And to you, Jane, Benjamin, and Roland, thank you so much for taking time out of your busy schedules to be with us here today and share your experiences, your insights, and your best practices. We're now going to hear from Bob Fangmeyer, the director of the Baldrige Performance Excellence Program, for a brief update on the Baldrige program. Bob?
Thanks, Al, and my thanks to our speakers as well. That was excellent. I'm not going to take a lot of time, but I did want to provide an update on what is happening in the program and some of the critical things that we expect to occur in the near future. First, as with just about everybody else, the pandemic has created challenges and opportunities for us. In order to protect the health and safety of our community, we postponed the award ceremony and the Quest for Excellence conference until next April, when we were going to have a combined celebration and conference for the 2019 and 2020 award recipients. Based on input from potential applicants, we decided to go forward with this year's award process, and therefore we needed to select and train examiners. However, we deemed it necessary to cancel the in-person examiner training, so in a matter of just a few weeks, we created online content and virtual training to meet our immediate needs. For the most part, the award process is already virtual, so there was not a lot of significant change needed for the independent review and the consensus review processes. Site visits, however, would be a different story. In addition to canceling on-site events that we host, it was also necessary to cancel on-site visits to various award recipient organizations as a part of the Baldrige Executive Fellows Program. And just this week, in consultation with the fellows themselves, we decided to cancel the remaining on-site visits for this year, and we will carry this cohort into next year, so they will have the full opportunity to visit with and learn from these role model organizations and their leaders. Of course, over the past year and a half or so, we've been collecting inputs and researching potential changes for the Baldrige framework. And in a few minutes from now, I'll be hosting the 5th of 6 focus groups that consist of diverse stakeholders and criteria users. We're helping to review all those inputs and recommend changes. Today's session is, interestingly enough, focused on organizational resilience and preparedness for disasters and emergencies. Very timely. Following the focus groups, we will begin drafting the changes. The drafts will go out for further review and input over the late summer, and final criteria will be released in January, as is our practice. We continue to work in partnership with the National Council for the American Worker to develop and implement a new presidential award to recognize excellence in workforce education, training, and retraining. And this award is called the Pledge to America's Workers Presidential Award. It's not a Baldrige award, but the criteria and the assessment rubric were derived from ours. Assessor training and acceptance of applications will occur during July. Evaluations will occur in August, and the first awards are slated to occur in September. Quickly now, moving on to other near-term activities. Earlier this morning, we notified all the award applicants for 2020 that should they be selected for a site visit this year, it will be a virtual site visit. The details of the process are still being worked out, but we have benchmarked several other programs that have successfully accomplished virtual site visits. We've discussed it with our judges and overseers, as well as with the applicants themselves. We will continue to involve the applicants in decisions related to the process itself as we go forward. For now, it's still a bit unclear, as I think you all can imagine, how things are going to play out and how soon we'll all be back to whatever becomes our new normal. So we're not clear yet what will happen with the events for next spring, but we will continue to make decisions as soon as possible and collaborate with all of our key stakeholders in doing so. Finally, despite the turmoil that's happening to this year's process, we still intend to be ready to roll out the new and improved revised award process starting next year. Al, that's all I have for today. Thank you very much.
Thank you, Bob. Our next presenter will be Brian Lassiter, the chair of the Alliance for Performance Excellence, for an update on Alliance programs. Brian?
Thanks, Al. I have 2 bullets and I'll take 30 seconds in the interest of time. We're really excited about the Baldrige Fall Conference coming up this fall, October 21st and 2nd. They'll be hosted in Milwaukee. You see the logo there, Excellence on Tap, little play on words. It'll also be provided online, given all the COVID conversation we just had and everybody's having. We'll have that option available as well. And I know that the team that's been planning it has really spent a lot of time directing the content and topics towards resilience and other relevant topics that build upon today's conversation and really address all the challenges that organizations are facing this year. Much like Bob said, the Alliance members themselves, the state, local, regional, and sector-based programs across the country have had to pivot as well. A lot of different programs are now being put online, webinars, workshops, roundtables, and other events. So I'd invite you to check out all of your local programs, the website there below, and see what type of programs are being offered now online. And with that, I'll hand it back over to you, Al, in the interest of time.
Well, speaking of pivoting on a dime and going virtual, so has the Foundation and the Institute for Performance Excellence. Just a reminder to everybody out there that you can train on your own pace online with us and get certified in Lean, Six Sigma, diversity and inclusion, project management, and data analytics classes, with more to follow. We've had unbelievably popular, exciting comments back on all of our training. And so I encourage each of you to check out this training for you and your organization. There are group discounts available, as well as discounts for partners of the Institute. Lastly, I want to once again thank Chuck Stokes, Roland Stacy, Benjamin Anderson, and Jane Pope for such engaging conversation today. That is the purpose of these webinars, to bring to you relevant, contemporary issues and best practices to help you lead your organizations. And lastly, thanks to our sponsors and our donors out there, especially those of the Mac Baldrige Society who are the Institute trustees, the Baldrige family, Adventist Health, Stellar Solutions, and Midway USA. Once again, everybody, thank you so much for your time today, and enjoy your weekend.